Die beiden sind online.
Ja. Hello and a wonderful good afternoon from Bavaria. Sunny Bavaria, finally after 1 week of rain.
Yeah, very sunny, no floods anymore. Yes. And it's the first online academy, the international one, after the summer break.
Season opening, everybody. Season opening. Welcome to the online session, online version of FotoFinder Academy. And we're going to have some very, very interesting events actually ahead of us, Katrin, right? Every month, an interesting topic.
Yes, exactly. And today it's a very, very special topic we never had before.
Yeah, it's actually more than what we know from dermoscopy and body mapping. Something, you call it the three-step. I sometimes say it's a new dimension. What is it?
This three-step method of digital follow-up. Some of you might know the two-step method already, which is the combination of total body photography and dermoscopy. But we added a third dimension. Tell us what it is.
People, today we will literally blow up your mind. And it's gonna just happen by the wonderful presentations prepared by our two speakers, because they are already working with FotoFinder in a different dimensions, because they are equipped with a piece of hardware that many of you don't know yet. It's in development. But we thought maybe such an event is a perfect moment to show you what is actually possible, meanwhile, with imaging. And therefore, we invited these two wonderful guests.
Yes, exactly. And I introduce the first guest, which is from Italy. It's Elisa Cinotti from Siena. And Elisa is a dermatology professor at the University Hospital of Siena. But her main field of research is confocal microscopy and the optical super high magnification dermoscopy, which we will have today as the third dimension. And she has 560 publications on ResearchGate. She's really a great researcher. And
she's the right person to dive into this topic, because that's so new.
Yeah, and she's the IDS Super High Magnification Task Force Chair.
That's
what a nice...
Elisa, where are you? Hello to you from Bavaria to wonderful Pisa. Today, Elisa...
Hello, I'm in Pisa now, in Tuscany. Nice to see you.
Elisa, it's a great pleasure to have you with us today.
Okay, let's start.
Wait a second. We have to introduce our second guest before...
Oh, sorry. Yes.
People, of course, as usual, FotoFinder Academy is interactive, and we invite always two speakers minimum. And in this case, we thought Elisa, with all her expertise in the publications, and actually one of the first persons who came up with the fact that we can use the super high magnification in many different fields. Another curious dermoscopist that you all know is sitting in Riga. The one and only wonderful Raimonds Karls is with us, a very welcome guest that you know for all these years accompanying us in the FotoFinder Academy. Raimonds, hello to you from Bavaria. How are you today?
Hello, I hope that I'm not only you can hear me, but also see me, but I cannot switch on my start my video. Yes, okay.
Now we can see you.
Yeah, hello. Yeah, hello.
Raimonds, welcome to this session. Today, for the first time, we have Raimonds and Elisa. It's the first time actually that we have both of them in the session. Perfect.
Yeah, it's my great honor to be on the same stage together with Elisa.
For me, the same as well.
Wonderful.
And we will start with Elisa, because she has to leave and has to work. So when do you have to leave, Elisa, exactly?
At 2:45.
Okay.
Very good. So we do a half-an-hour session, and then we have time for the questions. And in order to really dedicate the time to this wonderful presentation, we would pass the microphone to beautiful Pisa.
Maybe one question before you start with the presentation. How did you come into this field of research?
It was just for chance. I had a friend in Italy that showed me some amazing images about this technique that actually I think you know very well, Renato Rossi. And I saw also his first publication, and I was impressed. Actually, as you were saying, I'm very happy in working with confocal microscopy because I can observe the details, and I couldn't imagine that there was a dermoscope able to do so. And therefore, I was very, very interesting, and I started to understand what was visible. Because actually, my friend just showed me the impressive picture, but we didn't have any idea of what we were exactly seeing. And so we tried to understand, thanks also to the correlation you will see with this device and the non-invasive imaging techniques in general. And I think that now we have some knowledge that allowed us really to use it in clinical practice. But of course, we needed some years to understand what was visible.
Yeah, but in Italy, you even have now the CIDIA, the Italian Society of High Magnification Dermoscopy, which is really pioneering.
Everything starts always in
Yeah,
Italy and
Italy.
spreads worldwide. No,
Yeah.
Elisa, it's really impressive, really impressive. We look forward to your presentation and the cases you want to share with us today.
The stage
Okay.
is yours.
Thank you. So I am starting.
Yes, please.
Okay, I share. Okay. Okay, so good afternoon to everyone. I hope you're not too tired after the lunch. Thanks to FotoFinder for giving me this opportunity to present this new technique. So these are the images that are used to see every day in your clinical practice, those that can be obtained with 10-fold, 20-fold, 30-fold magnification dermoscopes. And now we can see better. We can see the details of these images as you have here in this 4 correlation between conventional dermoscopy and super high magnification dermoscopy. In the past, we were already using some high magnification, 50 folds, 70 folds, but this was mainly used to observe the details of parasites. As you can see here, all of you know that scabies can see as a triangle in conventional dermoscopy, but if you use a 70-fold magnification dermoscopes, you can really observe the entire parasites and even the eggs and the droppings of the parasites, like we have in confocal microscope. So with the dermoscope, we can have really more and more details using higher magnification. But until now, this technique, this higher magnification, weren't used for melanocytic lesions. We have also old publication on 1993 on the JAD that show us the possibility of using a 400-fold magnification to see the surface of the skin. But as you see, the images were quite blurred, and the clinician didn't see any interest in using this technique. And then we arrived to the publication of Renato Rossi, I told you before, this amazing correlation between the conventional dermoscopy and the super high magnification dermoscopy. It seems to be in a modern art museum with these amazing pictures. At the beginning, it was quite hard to understand what we were really observing. And the resolution has been done with this study, thanks to the patients also of my previous colleague, Jean-Luc Perrault, that is working in France. We have really the patient to find the same area in super high magnification dermoscopy and the same area of the same lesion using reflectant confocal microscopy. And you see really the correspondence. As you probably know, with confocal microscopy, we see pigment as a bright structures, so white structures. Here is a solar lentigo, here is a melanoma. So all these bright cells correspond to pigmented cells, pigmented keratinocytes and pigmented melanocytes in the lower part. With super high magnification, you can exactly see the same. So you have the pigmented keratinocytes and the same atypical melanocytes. And so this was really the demonstration that with a dermoscope, you can really observe single cells, pigmented cells in the skin. And of course, this is a revolution in the imaging field. What should we use? We use a FotoFinder device, and we just have to change the terminal lens. The field of view is very small. We can really see a small part of the lesion, 1 millimeter per 0.6 millimeter. So we have to navigate inside the lesion to have an overview. And how can we do? We have to change our lens and just put a specific lens that has been created to obtain this higher magnification. And you see that there is a ring on this lens that we can move, and with this movement we can adjust the focus. We can go a bit deeper inside the skin. Okay, what can we observe? We can observe details of pigmented structures. I show you pigmented cells, both keratinocytes and atypical melanocytes, both roundish and dendritic atypical melanocytes, and melanophages. Normal melanocytes are impossible to be differentiated by keratinocytes, as is in refractive confocal microscopy, because they have a similar shape and size. And we can observe the architecture of the dermal epidermal junction when we have pigmented cells inside. This was a case that really pushed us to work in this field. This was a patient that was coming back from holidays with this pigmented patch. And this is the dermoscopic appearance. So you have elongated pigmented structures. Some of you probably already made the diagnosis. I knew that the majority of the public today is an expert in dermoscopy. So probably you got the diagnosis, but with the super high magnification dermoscopy, it's much easier. You see these dark filaments, and we can also see some round structures. And these, of course, are the filaments and the conidia of the Tinea nigra. And this was confirmed by the culture. So in just a few seconds, you have a smart diagnosis, and this was very, very useful in our case. So what you can see? I told you that you can see keratinocytes that appear as polygonal, regular, mostly in focus cells that are spread inside the network. We can see them in solar lentigo, in junction nevi. And another case, you can see very well these roundish structures that are homogeneous, more or less in size. Of course, in some area they are more or less pigmented. It depends on the quantity of melanin that they have. And in melanomas, you can really observe very, very large cells, atypical cells. You can see here. Can you see my arrows? I hope so. Probably not. I put it, now it's better. So you can see that we have really large cells of different shape and size, and this is 100% specific for melanoma, of course. You can see again here, we can observe both elongated cell with a dendritic shape or roundish cells, as you can see here, corresponding to atypical melanocytes in a melanoma. Melanophages appear as blurred cells out of focus, but because they are deeper located, they are large, and they have a color that could change between blue, violet, and gray. Let's see what happens in case of a blue lesion. This is probably a blue nevus. You have an homogeneous pattern, and using this technique, of course, you cannot see anything. This technique is useful to observe the detail of the superficial part of the skin. So we can see very well the pigmentation inside the epidermis, at the junction, in the superficial dermis. But of course, if you go deeper, you cannot see any details. can be useful in our experience, yes, to identify atypical melanocytes and also to use it in case of lentigo maligna. I will show you some cases, and also to diagnose basal cell carcinoma. This was the first study that we perform, and we compare melanomas and atypical nevi in conventional dermoscopy, and we could really see some differences. You can see the atypical cells of the melanomas, the melanophages in the area of regression, and here the normal pigmented keratinocytes and melanocytes. And in our study, what was really different among melanocytes and nevi was really the presence of atypical melanocytes in melanoma. We also describe other criteria, but they are less robust compared to the presence of atypical cells. Let's see some example. This is a lesion on the chest. This is the dermoscopic appearance. You can see that we have a network, maybe some area of regression, so it's a dyschromic lesion, not very clear. If we use super high magnification dermoscopy, you see very well that we have homogeneous pigmented cells that could correspond to pigmented keratinocytes or pigmented melanocytes in a case of a junctional nevus. And we could find a good correspondence with the confocal microscopy. So this, of course, was just a nevus. This is a lesion that is already worrisome under conventional dermoscopy. Of course, we have a grayish structures, we have an atypical network. And if you observe with super high magnification dermoscopy, you see immediately large cells here that are also elongated with the dendrites. So, of course, the previous lesion was already worrisome under conventional dermoscopy, but with super high magnification dermoscopy, no doubts. This is a clear-cut melanoma, and you can excise this lesion already with 1 centimeter margins. And you observe here these atypical cells inside the lesion. So is really, really specific for the diagnosis of melanoma. And we had also a good correlation with confocal microscopy. And what is interesting is that with confocal microscopy, you see less atypical cells compared to dermoscopy. Because, of course, reflectant confocal microscopy give you the image of 1 thin layer of the skin. Whereas with dermoscopy, you have a superimposition of multiple layers, and therefore you see an increased number of atypical cells. What do you see in this case? This could be a difficult image to be interpreted. This is a super high magnification dermoscopy image. If you put conventional dermoscopy together, it's easier. Of course, this is a classical example of melanomas. But if you look carefully with super high magnification dermoscopy, you can really see the atypical cells. You can see these elongated cells, which correspond to malignant melanocytes, and also these very well-defined roundish cells, and again here, these very large cells. So, of course, as I told you before, the field of view is very small. In case of a large lesion, I mean, usually at least a few millimeters, we have really to go around in the lesion to find the area of interest. In nevi, what we observe is mainly the presence of homogeneous pigmented cells that could correspond either to pigmented keratinocytes. We know very well that mostly in junctional nevus we have a pigmentation of keratinocytes in the epidermis. And we see very well the network. The network that we see with conventional dermoscopy is formed by single cells. Another case here, we can see in some area it's easy to identify single cells. In some area we see more an homogeneous pigmentation because we have many cells that are superimposed one on the other. But we see that we don't have any large strange cells. Another case with conventional dermoscopy, I wanted to show you how this part is seen using super high magnification dermoscopy. Of course, we can interpret this as a black lamella, a pigmentation of a stratum corneum, and in fact, we can see that we have very well visible pigmented cells in the upper layer of the skin that correspond to pigmented keratinocytes, and if we play with the ring, we can really adjust the focus and we can go deeper. So we can have an idea of a three-dimensional view, and we can know where is the pigmentation. Another case, this of course is an easy case of lentigo-maligna melanoma with an impressive nodular lesion on the forehead. But what is nice that you can really observe the atypical melanocytes inside the nodule. What we can see using this technique is mainly the presence of pagetoid cells. So in all the melanomas that have pagetoid spreads, we can observe very well these cells that are going in the upper layer of the skin. More difficult is to observe the presence of atypical cells at the level of the dermal-epidermal junction because we have also the normal keratinocytes that are around, and in this case is much more difficult. Another example, this was a patch on the face, and this is the conventional dermoscopy. What can you see here? I think that most of you will speak about the pseudo network. Is a pattern that is found in solar lentigo. So apparently this is a benign lesion. But if you see with super high magnification dermoscopy, the aspect is completely different. You have really monstrous cells. You see here very large cells with long dendrites. We have rounded cells, and we have large cells around the hair follicles. So this is folliculotropism, and this is a sign, of course, of lentigo maligna. So this lesion that could resemble to lentigo maligna because it was an isolated lesion on the face. With conventional dermoscopy, the diagnosis was more in favor of benign lesion, but thanks to the high magnification, we could really make the right diagnosis. And yes, we published a study on this topic. Another example of a lesion of the face, we have the pigmentation that is distributed around the hair follicles. The general appearance is that one of solar lentigo, even if we have some area of accentuation of the pigment around the hair follicles. And here you can see very well the nice cells around the papilla. And this is an hair follicle that is paired. And so these are pigmented keratinocytes in the case of the solar lentigo. Another case, you have an aspect more or less of a solar lentigo, but we have some grayish structures here. And with super high magnification, you see very well these nice polygonal cells. Also here around the hair follicle that is paired, and this, of course, was a solar lentigo. Another case here, of course, we see already a pattern that is typical of solar lentigo using a conventional dermoscopy. Here in the upper part we have probably a flexible keratosis. But anyway, it's interesting to observe how this pattern is well recognized using the higher magnification with a very good correlation with confocal microscopy. You can see very well the pigmented keratinocytes with this, we call it in Italian the sausage aspect of these epidermal ridges that are elongated. In our case, on the face, we have this peppering with grayish dots that are irregularly distributed all over this lesion. And using the super high magnification dermoscopy, we can see large blurred cells, grayish cells, that spared the hair follicles. You can see here very well these cells that are quite homogeneous, and we have the correlation with OCT. This is the epidermis, and beneath the epidermis, in the dermis, we have these bright cells that correspond to melanophages. So, of course, this is a lichenoid keratosis. And what is interesting that here you see very well in OCT and you see very well in super high magnification dermoscopy, you don't have any pigmentation in the epidermis. So you have only this blurred pigmentation, these blurred cells, but of course they are located in the dermis because they are not so well defined. If they were well defined, they would have been in the epidermis. Since they are so blurred, this indicates that they are deeper and they correspond to melanophages in the dermis. This is a nice case of a basal cell carcinoma, easy case for all of you with conventional dermoscopy, but it's interesting to see what we can observe using this high magnification. It's impressive. You see these areas that are homogeneous, yellowish, pinkish, pretty well defined areas that of course correspond to the basal oil islands. And inside the basal oil island, we can see many pigmented cells that correspond to some cells of basal cell carcinoma that are pigmented. You can see very well, in some cases, they are more elongated because you know that in basal cell carcinoma, we can have also pigmented melanocytes inside. And so you can see here both pigmented melanocytes and pigmented cells of a basal cell carcinoma with a very good correlation with this OCT imaging. So this is the tumor island, and here is the tumor island in OCT. And we see in the same case that we have pigmented cells inside the tumor island and hyperreflective cells inside the tumor island that correspond to the same cells. And you can see here also in the video that we have really large pigmented cells in this basal cell carcinoma that often they are not seen under conventional dermoscopy, but are very well visible with this technique. Another case, this is a more challenging case from a dermoscopic point of view because we have linear vessels, the lesion is not so well defined, it's a pinkish lesion, we have some dots, but it's not so clear cut. We can observe with super high magnification dermoscopy enlarged vessels, but of course it's sometimes hard to identify if they are regular or irregular with so high magnification. And again, you see this area, this tumor island that are pretty defined, that are yellowish or pinkish with these pigmented cells inside. Another case, another basal cell carcinoma, and you find again this aspect with these pinkish, yellowish areas with these pigmented cells inside. Here you have also erosions. And the correlation with the confocal microscopy, where you can see these hyperreflective cells that correspond to basaloid cells that are pigmented and melanocytes. In case of dermal nevi, as you can see here with globules, what you can see is really impressive. The same aspect of confocal microscopy. We can see roundish cells that are completely pigmented or just pigmented in the outer part, as you can see here. And they are very, very homogeneous in size and shape. And this is characteristic of dermal nevi. So it can be useful to use this technique in order to differentiate dermal divide that has these roundish homogeneous cells from basal cell carcinoma that has more irregular cells that are always in the context of a pinkish, yellowish, well-defined background. I'm a bit late, but I will give you just a few information about a new possibility. Some of you maybe know that I'm very interested in the field of mucosa. This was a patient that had a surgery from the gynecologist because this pigmentation that is a benign pigmentation is mucosal melanosis was interpreted as a melanoma because of the high pigment of irregular shape and multifocal pigmentation. This pigmentation came back again, and luckily this patient was sent to me, and I performed a confocal microscopy examination, and I could reassure the gynecologist that this was a benign melanosis thanks to confocal microscopy. And now I can do the same using the super high magnification dermoscopy. So you can see here how this technique can really correlate with the images of confocal microscopy. As you know, melanosis is just a pigmentation of the basal layer of the epithelium and the mucosa, and therefore we have a pigmented ring in confocal microscopy at the level of the dermal junction or epithelium colon junction in the mucosa, and we can see the same rings, normal rings, using this technique. This technique is particularly interesting in the mucosa because, of course, we don't have the stratum corneum, so we can go deeper. And I could really see the details. You see, this is a melanosis with a proliferation of melanocytes, and I could really have very good correlation with confocal microscopy. I go a bit farther, and I want also to underline that this technique can also be used to see the parasites, as we were doing in the past, details of demodex, which are very clear here. And also we could see some pigmented demodex that were never described before in case of pigmented lesion. Probably the parasite just absorbs the pigment that is released by the different pigmented lesions. And there is also a very nice publication showing the details of these Pyrrhus pubian and pediculus capitis using a super high magnification dermoscopy. So in conclusion, we can observe many features. We can observe the details of pigmented structure. We can observe the pigmented keratinocytes, typical melanocytes, melanophages, the architecture of the dermal epidermal junctions. This technique can be really useful to help us for the diagnosis of skin tumors and to identify details of parasites. As we said before, we have a task force of the IDS. Raimonds Karls is also an active member of this task force, and we are trying to see what we can really observe and to make the study together of this technique. And I will leave you with these images of macro photography. You see how the details can make the difference when we observe the nature. And I also invite you in Argentina. There is the IDS World Congress, and there will be also a session on super high magnification dermoscopy. Thank you to all of you for your attention.
Thank you, Elisa, for this wonderful presentation.
Thank you.
Amazing to see the different cases, the incredible image quality. I mean, the focus, finding the focus in different skin layers is definitely one of the, key features of this new technique. And your images were just impressive how you've done it with different type of lesions.
Absolutely. Raimonds, what's your impression?
Oh, I will say that I also impressed as usually by Elisa presentation, and she covered everything. That's my pleasure will be only to show cases because Elisa explained almost all fields of the super high magnification.
This is
Thank you,
But
Karl.
it's really very interesting. It's like a universe of absolutely new dimensions.
Yeah.
But maybe I would like to ask Elisa about what is the percentage of the replaced confocal cases with this technique? What
For
is your
me, it's harder to answer this question because once the patient enter in my room, it never can go out because I start with dermoscopy. Then I do the super high magnification dermoscopy, I do confocal, I do CT. So I'm always using all my techniques in a patient. But it's true that now I see that mainly for the mucosal cases, I really prefer to use the super high magnification dermoscopy than confocal. Then concerning the melanocytic lesion, of course, we can see very well the typical melanocytes when we have pagetoid cells, but if we have a typical melanocyte at the junction, it could be more challenging to observe them. So I think that we still have to study together, to put our cases together and identify first the limitation of our techniques in order to know where are the fields of use and in order not to be too much confident, you know, because of course there are limitations of this technique compared to confocal microscopy. I think that we still have to know. In some cases, I find it that is more useful, in other not. For the mucosa, it's very, very useful in my view because you don't have the stratum corneum, and so you really appreciate the details.
Very good. So I think we have got already also another question. Catherine, can you read it?
How long does it take to scan a single skin lesion with a super high magnification? Is the question.
It's up to you. Of course, you have an immediate image, but as I told you, is a very limited field of view. So the best is to navigate around. It's very hard to know if you can cover the entire lesion because we don't have an identification of the area that is imaged compared to conventional dermoscopy. So you have to go around, and of course you have to adjust the focus. I try a new device of FotoFinder that has an automatic focus, but still I think that having the possibility of adjusting the focus is useful because you can understand where the cells are located, if they are in the upper part of the skin or if they are deeper.
Yeah.
Located.
But I think it will be very well to note that we just change the lens, and it's immediately we are ready to go with the super high magnification. We need not to switch to the confocal.
I will show it in live in a second. In a couple of minutes, we will look at it in live, because I think only when you see it, how we switch the lenses, you can have an imagination. The other question is, do you use it also on acral lesions?
Yeah, I try. Actually, it happens to me to have some cases of acral melanoma with wonderful cells, atypical melanocytes that were visible, because often in acral melanoma you have the pagetoid spread, and this was visible. Then to observe junctional nevus, it can be more challenging. But it's true that I have some cases of melanomas where I could see very well the atypical cells because they were superficial.
Oh, very nice. People, I have to tell you, while during the presentation, I was just telling Catherine, this field is a new field, and obviously also this session is quite is addressing the experts in dermoscopy who are also having some experience in confocal. I think that is when your eye generally gets attracted to the images, when you have a confocal experience. Also, I mean, at the level of histopathology, for sure, when you have got the understanding of the vertical view of the scene, you will be automatically more attracted to the high magnification. Our goal is obviously always to start creating the awareness. And we know that this is the beginning of a journey. Elisa, you perfectly mentioned it. We need to still do a lot of research. Our goal is to have an atlas of optical super high magnification. That's the way to go.
Yes, and there's one more question. Is it useful to examine scalp and hair disorders? So trichoscopy with super high magnification?
For hair disorder, not so sure, but why not? We could start. I don't have much experience in the scalp, at least for me. I don't know about Karls.
No, for this, I think, I don't know, Raimonds, have you talked to anybody on trichoscopy about this?
Not yet, but I think it's just need to find someone engaged person and everything will be done.
No, for sure. I mean, the team around Professor Rutniska in Warsaw is definitely, they have incredible access to equipment. We will meet her next week at the EADV. And I think that's to the person who asked this question, we will come back to you with an answer hopefully soon, okay?
Of course, everything is new, so we have to try and we have to discover.
True, true. No, this is wonderful. Elisa, maybe just to tell you, thank you very much that despite your busy schedule, you accepted our invitation for this session. And I look forward to meeting you together with Catherine and our team next week, the EADV, when we come together with the entire group that is working on this wonderful technique within the IDS. And I am sure this is not going to be the last FotoFinder Academy invitation for you.
Thank you to all of you. Thank you also to Raimonds that has shared with me this session, and hope to see you soon. Bye.
Very good.
Bye, bye, bye.
Bye-bye.
Bye-bye.
So people, in my opinion, in order to make this a little bit more tangible, how this is, I would like to show you in a couple of minutes how I mean, many of you already have a FotoFinder, probably just to see how does this work? How would you use the software for it? So in order to get ready for that, I have to undress myself.
Oh, this.
I'm not going to get completely naked, guys, not this time. But Raimonds, maybe I'm going to take a lesion on my arm, and I will need your help to guide me a little bit. So people,
You will be my virtual patient, yeah, my distant patient.
Yes.
Very good.
Look,
I will just enjoy.
many of you are using your FotoFinder Medicam with an optic that you use for the normal dermoscopy day to day. So whenever you have got such a machine delivered, you get this optic automatically with the camera. Now there is a new optics that we have developed for super high magnification. This is with heavy optic, obviously. It comes with more layers and allows a much higher magnification compared to the standard optics, which is the D-scope. So as you see, Raimond has got it in his hands. Very good. So as you see, it's the same camera, two optics. So the most efficient way of also investment. We don't want to, again, add more hardware. We want to keep it in a way absolutely efficient. So I would maybe share my screen here. And then I start doing some pictures with a high magnification, and we would, with Raimond's help, maybe start doing some interpretation. So I will activate the FotoFinder camera, use some immersion on my skin, because I have to say, maybe, Raimonds, do you use gel or do you use immersion when you do the high magnification?
More, it depends, but more usually I'm using alcohol, just 1 or 2 drops of alcohol, because in this case, we really need a very good contact with the surface.
That's also what I did. But guys, look at this. I mean, this is a lesion on my arm. I am trying to get myself, and you see, I'm just diving into this lesion. And Raimonds, I think when we looking back at Elisa's talk about the dermal papilla and the structure of the cells, I think this is immediately visible. I mean, I want to show how simple it is to get actually meanwhile a focus with this optics?
Yes, and we see two different things. We see this network, and we see also these shadows of the cells, and also the pigment, which is a little bit higher than the retroridges.
True.
That means that we see some kind of like a dust on the surface.
Exactly. But again, with the magnification, I can basically go between the skin layers. And again, the new optics, the softwares that we are developing allow this to be fast. I mean, the question from the audience is very relevant. How much time do I need to really get to that level of visibility? And I tried now quickly to show you that it's meanwhile quite fast. Raimonds, is this lesion at the level of dermal papilla and cell structure quite harmonic and, let's say, not irregular, hopefully?
I feel confident about your lesion and about your, yeah.
Thank you. Thank you. People, I suppose, again, if we again come back to the actual configuration, when we started with the development of this optics, our goal was to make it in the most efficient way possible. I think, Catherine, Renato Rossi, as a friend of yours, when he contacted us with his findings and said, guys, this is a case, you have to really take care about it. And that was such a motivation in the development. And it was already the beginning to say, let's do it efficient in a way that we don't need another camera, another card. Let's make it compatible, let's say. Yeah. And I think that's something that we achieved.
Exactly. And Renato is a true pioneer also he was exploring how he was one of the first or even the first to use it and to really find new pattern and to dive into this new technology.
But guys, can I tell you my personal experience with this device? I remember it was maybe 10 years ago, and one of the professors that you also know maybe from University of Vienna, Professor Knobler, he came to me and he said, "Hey Moa, I am basically looking for a good capillaroscope. And do you think you can provide us with a good capillaroscope?" And that was the first time when we actually were thinking about this device to be also quite interesting in the field of capillaroscopy. I want to show you that this is really very also interesting when it comes to nail fold capillaroscopy. Of course, I'm not maybe the perfect patient for capillaroscopy, but still you can see that it's possible to find the capillars and even the shape of them, okay? So it's really something very interesting with this lens that at the beginning, it was mainly used very often also for nail fold capillaroscopy in the University of Vienna. Raimonds, are you using it also for this type of purposes sometimes?
You know, I will say that we are using for the examination of the capillaries, and I will show some cases, especially when we are talking about the dotted vessels and glomerular vessels, and when we are talking about regular and irregular vessels, and there are really interesting observations. Regarding the true capillaroscopy of the nail fold, not so, but in tumors, yes.
One more question, Raimonds, as we're talking about the three-step method. You see here the ATBM master, standing in front of the total body mapping machine, then the classical Medicam for dermoscopy and the special lens for the 400 times magnification. How do you use it? Because Elisa talked more from the scientific part, but you are really you're running a clinic, a busy clinic with lots of patients. Do you really also use it for the daily work?
Yes, for sure, because this is like a essential part when we are going to the some points like dysplastic versus in situ and flat lesions on the face when we need to differentiate. Of course, this lens is available to all doctors, and they are switching and they are doing everyday practice.
So this is a good introduction because now we get excited to see your cases, right?
Yes, absolutely.
Share with us your practical cases. This brings us a bit closer to the daily reality of super high magnification.
And for a great honor to share my cases from Riga. So hope my screen is visible. And I will also take a pointer. Okay, so, let's talk about the three-step method of digital follow-up. And here we really can see that total body mapping, video digital dermoscopy, and optical super high magnification. And yes, in next 30 minutes, I will try to show how we are doing our practice in this. And I will start with a little bit interesting question. How can we understand that this is a melanoma? And we can do it very easy by naked eye, when we need not to have a dermatoscope, we need not to have a digital dermoscopy, we need not to make follow-ups. We can say that this is melanoma clinically. Of course, with some questions regarding, is it really melanoma? But this is true, this is melanoma. Next step is with equipment, when we have a clinically asymptomatic lesion, and when we apply a dermatoscope, we are saying, well, this is bad, this is a melanoma. And then there is a third step. I will say this is a third step before the super high magnification. When we need to make a monitoring, we are doing monitoring. Of course, we can excise immediately or we can ignore, but we can say that this is a melanoma by using the equipment and digital follow-up. Yeah, this is our daily practice. And for sure, at this moment, it's not so easy to say that this is a really melanoma. It's quite a symmetric lesion, and we know that this lesion undergo changes, and this lesion is a property of 27 years old gentleman, but this is melanoma. And at this point, this is a case when I see a really application of super high magnification or confocal microscopy, because we need to look into this lesion. Yeah. That's why the question is, what else could be done? And what else could be done? I would like to show with one clinical case what else should be done. Of course, this is a super high magnification, and we see pigmented lesion on the frontal aspect of the 72 years old lady, and quite regular, of course, for the big bosses of clinical oncology. They will say that this is suspicious for sub-K, for basal cell carcinoma. This is really basal cell carcinoma under polarized and non-polarized dermoscopy, and we see these differences by presence of shiny white structures. We see arborizing vessels, and we also see these pigmented structures. And at this moment, we can we can move to the excision, but before this, we can also take a look into the literature data, and we see that there is application of super high magnification for pigmented basal cell carcinomas. And let's jump into this beautiful basal cell carcinoma by this area. And we really see irregular violet colored clots. And these clots are not just clots, this is cells. We see completely different small round cells which are located very close to this area. And here we can see two types: violet colored dendritic cells, yeah? And we also see small round violet cells. And of course, it's not so hard to understand that we are talking about the presence of the melanocytes and pigmented part of this photo. We know that navy are stable and melanoma undergo changes. This is something from the two-step approach, and this is a basal principle for dermoscopy, and we are saying that yes, they are stable. This is an example, April 2016, November 2018, and March 2021. in some instances, of course, these lesions can grow, and we know that growing is a very good feature for the young patients, and we are not so happy about the lesions on the older patients. And like here, it's just to show that yes, we are using different methods, and here we can see really that this lesion is growing and growing. And of course, at this moment, we haven't access to the super high magnification, and it was necessary excise, and this was melanoma Breslow 0.4. Why we decide to excise? Because this lesion was completely different in comparison to other lesions of these gentlemen. This is also very well known rule for the digital follow-up. Another one case, again, this is a young lady with changes of one single lesion. And here again, lesion first photo in 2017, and then follow-up. We also skip some sessions. We did not perform this digital dermoscopy. Why? Because this lesion was not changeable. And in January 2021, we see that there is appearance of the new area. And I will say that in this point, this will be a very, very interesting to apply the new technology of super high magnification. And we will be much more sure about the diagnosis. Of course, it's a little bit later was excised, and it was melanoma in situ. Of course, when we are talking about two-step approach, we are talking about quite old approach. It's published 1988 for the dysplastic nevi, and we see in this publication that at those time our colleagues performed these follow-ups using the color slides, showing these pictures on the screen and comparing what is going on. And of course, since approximately 15 years, we are talking about already mentioned two-step method. And today we are talking about the three-step method. And two-step method is, yes, this is a total body photography together with a digital dermoscopy, signature pattern of the current patient. And I will say that this is also a very good application for the patients of the high risk, as we know very well, especially for inherited melanoma gene like this. What we see previously, it was a father, and there is a son. There is a first visit in 2019 because the father had a melanoma, and for safety reason was performed this total body photography because this gentleman also have a lot of nevi. And 5 years later, we see that, yeah, one of the lesions undergo changes. And previously, 5 years ago, this lesion also was there. Yeah, and by applying the dermoscopy and looking for the structureless areas, which belongs to the congenital nevus terminal hairs, also the feature of the very close located congenital nevus, and pigment network here, and pigment network here, and negative network here. And of course, putting all together, we are saying that this is a lesion for excision, and it was melanoma in situ. And by the way, for those today, I understand that there are experts of dermoscopy, but asking also artificial intelligence, we find that artificial intelligence is saying, yes, no, that looks not so good. This is again melanoma in situ. But let's go back to the third step, as already Elisa mentioned, and in our clinic, the bigger field of application of the super high magnification is flat pigmented lesions on the face. Yes, we have quite pale patients because we are located almost in Scandinavia, and sun is shining during the summertime, and our patients are pale, but they like to undergo sun. And here we see just a high magnification dermoscopy, and this is a super high magnification, just to show how the difference is, what the differences we can see in case of solar lentigo, lentigo maligna, and pigmented actinic keratosis. We see very well demarcated cells and well visible. In lentigo maligna, we see these cells with a irregular shape, and in case of pigmented AK, we see mostly grayish colored clots. So small brown round clots on the left, irregular dendritic cells in case of lentigo maligna, and irregular shape and size brown cells on the right side. The same we can also see observations on the halo nevi as here. Clinically, it's very easy. Dermoscopically, also very easy. But we are usually saying about the regression. And here we can see a very good example how this regression really looks like, gray color and features of regression here. And at the same time, we see these melanocytes, which is in many areas visible as a very well demarcated cells. So this is a halo news. So next, again, mixing together 2 steps and 3 steps, I would ask to about your opinion, is this melanoma or not? And I will show you is this melanoma or not. Here is a patient. We follow him starting from 2017 up to 2023, a patient with a melanoma history in his family and also melanoma history in his own history. And the lesion at the very beginning was like this. And here we can see undergo changes and digital follow-up, still, and at this point we decide to stop the follow-up because we very well known that these melanomas in these patients could looks like really banal nevus, but these nevus undergo changes. This is this lesion we see in between many of irregular lesions, this one, and there is comparison of the same lesion and more than 5 years in between. And also here will be very interesting to apply super high magnification, but it was excised without super high magnification, and Breslow was 0.3 millimeters. And Mocha asked me about the examination of the vessels. I would like to show my favorite application because usually when the young colleagues are coming, the eyes became very, very bright because they see something what they never see before. And I think that some of participants already have seen this case, but I will show. This is a clinically looks suspicious for basal cell carcinoma, and this is also looks like basal cell carcinoma, polarized, non-polarized. But usually I'm asking one question: what is the blood flow in the vessels when we are observing basal cell carcinoma? When we are teaching dermoscopy, we are saying that arborizing vessels starts from the periphery and going to the central part. And here is the branching. The diameter is becoming smaller. They are not crossing the central part. And one of the ideas that the blood flow could be from the periphery to the center. Another one idea, why not, that blood flow could be from the center to periphery. Or maybe this could be in both directions, from the center to periphery or from periphery to center. Let's take a look, super high magnification of the blood flow in this current basal cell carcinoma, and we see that these erythrocytes are running from the sharply demarcated vessel to blurred area. It means from the center to periphery. Another one branch, again, we see that there is a mainly blood flow from the center is going to periphery. Of course, the question is about what is the scientific and what is the practical application of this. I think that we will see in the next years also the application of the blood flow in the tumors. And here the same. What is necessary to note that, of course, this is a two-dimensional visualization, and this is not three-dimensional. That's why in some small branches we see this blood flow is going really in two directions, but in the main vessels, it's going from the center to periphery. And as I already mentioned, this is also a very interesting observation regarding the dotted vessels and glomerular vessels, and especially in the small non-pigmented melanomas and differentiation of the pinkish lesions of like psoriasis versus non-pigmented melanoma. This is nodular basal cell carcinoma with a blood flow. What else could be done? What else could be done? Of course, we are comparing and we are really doing a lot of things in comparison with globular and reticular pattern. And for those who are really have seen these photos first time, we are saying that this is a globular pattern with dots and clots, and we're saying that this is a reticular pattern. And going deeper to what also Mo showing on his hand, we're going a little bit more deeper, and of course these cells located around the papillas, they are really regular, they are uniform, they are roundish, yeah, and this is solar lentigo. And in comparison, we see that there are some dendritic structures, like here, this really is a peripheral globule in one growing nevus, and in comparison to the just reticular type of lesions. Scattered structures and cells, and violet color for melanocytes, and mostly brown color for keratinocytes. And now putting all three steps together, female, 62 years old, no history of family melanoma, history of previous melanoma in her own history, few navy on the trunk. This is this lady. This is a scar after first surgery. Really, lady is following all the recommendations, and after I usually saying that if we find a melanoma on your body, our friendship not ending, but our friendship starts in real force, yeah, because patients after melanoma, they need these follow-ups much more. So 2020, I can ask, do you see a new melanoma on the body? It's all trick, because it's it could be any of these dots. Next, 2021, again, any of the dots. Then 2022, okay, any of the dots. And 2023, we really see that this melanoma is presenting here. Where is a melanoma? Of course, we can find this melanoma first by comparison baseline and current, and by the using of modern technologies, and also by using by FotoFinder, we see these yellow and red rings around. And we see some dots, and we will go closer to this dot, yeah, here. and we see really it's continued to grow. And of course, at this moment, we are applying dermoscopy and comparing with the previous. And this is a dermoscopy. And this is a dermoscopy of this lesion. And another one question, non-polarized and polarized dermoscopy, do we see some differences? Yes, we see almost the same. Maybe no, maybe on the screen it looks a little bit different, but what we see some peripheral globules, and there are also data published on the use of super high magnification for the peripheral rim of globules. And let's take a look. Here one globule, here another one, here and here. And also we see some white line. Of course, it's a very good question. Is this shiny white structure or no? Because if this is shiny white structure, this is more probably that this will be a melanoma. But this is just one point. And some dotted vessels. For me, as a user of super high magnification, for me, it's very interesting to take a look for these peripheral globules. And one of my students 2 years ago make a project about the peripheral rim of globules. And we find that if we have a really growing nevus, the cells in peripheral rim of globules are very regular. In case of melanoma, we will see different cells. Here we see the super high magnification and we see small cells. This is melanocytes and just one dendritic and one with irregular shape. So we go through all these peripheral globules and the finding was very, very similar. Then let's go to this central part with the super high magnification. And here we clearly see that this is melanocytes, that these are irregular melanocytes by shape. And we see some of them are really dendritic. Some of them haven't these dendritic endings. And this was the point of decision that this lesion no more follow-up, but this must be excised. And just this morning, preparing the final slides of my talk for this FotoFinder Academy session, morphologist called me and said, congratulations, you find a melanoma in situ. So this is a really application of all three. It's total body photography, digital dermoscopy, and also super high magnification in one patient. I think that these cases will be much more in the future because we are really open a new dimension of these early diagnostics. And that's also another one question regarding our morphologists. Are they able to recognize so early melanomas? So this is my story, and I think that there will be some more interesting stories also during the EADV. That's why at this moment I would like to say thank you for your attention. Some more cases also will be represented on EADV Congress on IDS session in few days from today, next week in Amsterdam. And also I hope to see you all on FotoFinder DermLight booth for live demonstration of technologies of our daily routine. So,
Raimonds,
lots of hearts coming up.
lots of hearts. You won the hearts, Raimonds. You won the hearts. Raimonds,
yes.
let me do something. Again, I mean, the audience, please feel free to share your questions, obviously. And I wanted to let you know that based on the cases that you shared, it is, at least for us, a clear vision to say the 3 steps are already close to the actual reality. We start with body mapping, detect relevant lesions, and in early diagnosis, when it's really difficult to make a proper differential diagnosis, we have the higher magnification as a tool to save time and maximize the precision especially for those who might not have access to confocal. Confocal microscopy
yes.
is definitely a very, very precise tool, but it's an expensive tool and
It's
time.
also, it's very expensive. And as the lens approach to our clinic, I will say at this moment, no, I will say we need not confocal. We have a super high magnification. It really works very good.
But
of course, it cannot replace, and I agree with Elisa when she said that, of course, there are gray zone and there are also narrow areas, and but I think this method will grow and we will get new studies and also new data regarding the all locations, like a face, like also acral lesions, and we also will find a lot of interesting things on melanocytic and also non-melanocytic lesions.
do you think that this technique would even have a contribution to further education of confocal users? Because sometimes you see, of course, here stuff in color, and then the correlation, as Elisa showed, to the confocal images. Do you think it can be a very good educational tool?
I think yes, because really we can recognize different colors. We cannot do the same with the confocal because this is a black and white or gray scale, but here we see really gray. We can see also violet and also brown. And for also those who are starting their confocal career or studies or any other project, this will be a very good point, yes.
Then we have a 4-step method.
Yeah, why not?
Raimonds, the fact is that still we as manufacturer are deep involved in training of the 2-step method. We must be honest, we are still in many countries, there is huge need to learn the basic digital follow-up protocols. Of course, it might overwhelm some people when we show higher magnifications because it's again a new language. I mean, even at the level of terminology, I don't know. You are in this group of IDS. I mean, I think also a challenge is already the terminology, right?
I will say, yeah, but no, if we will take a look to dermoscopy, it's really the same because we have different terminologies, different approaches, and both approaches are, I will say, fruitful. And we are saying that this is network, but no, at the same time, we are saying reticular lines. Yeah, I think that terminology is important. Yes, it's important, but at the same time, it's only I will say that terminology helps, but also 25 and 30 years ago, when the dermoscopy appears as a new kid on the block, everybody was saying what dermatologists are doing. They are looking into the magnification and light and saying there's some diagnosis. And there was a lot of doctors who was doing ha about this, but nowadays we are saying that, wow, this is really good method, and if not the gold standard, but very close to gold standard. And this is only development of the soft development of the lens, and okay, also collecting of the data and putting all together. I will say that we are really opening the door of true in situ melanomas and very early tumors.
Especially your cases on facial lesions. To be honest, Raimonds, I really thank you because you shared these cases with me. As I myself, together with Catherine, we are very curious to understand how this tool can really save time and be valuable in daily practice. I took it to Queensland, Australia, and the Australian the National Congress of Skin Cancer, and really just the differential diagnosis of lentigo maligna, pigmented actinic keratosis, and on the facial lesion is something that is very, very welcome by the experts who are seeing this at daily basis. You know, that's something that at daily basis creates challenges, especially in countries like South Africa and Australia.
But also for us, for Baltic region, it's the same. We also have a patients with a pigmented actinic keratosis. We also have a patients with a early subcase and also lentigo maligna. Yeah, and of course, I hope that in 10 or 15 years, these ugly cases, the amount of ugly cases with a huge lentigo maligna will be much less, and these tumors must be recognized earlier.
Guys, let us do the following. Let us answer one question. Meanwhile, my team is going to prepare one poll. We have one question prepared for this session, which gives us a little bit of answers also of the audience to the questions that I asked. The question of the audience is, Catherine, can you read
With
it?
higher magnification, how do you recommend to do the follow-up? Do you do it as regular in 3 months? Or do you think with who it could be better to do it in 1 month?
So this is a very good question. Why? Because at this moment we haven't data regarding the follow-ups in this method. We know with the digital dermoscopy that we are doing the follow-up of the current lesion in 3-4 months, and we are saying, well, we have enough data that in this time period malignant lesions have some changes. I think, and my personal feeling is that in case of super high magnification, this time will be shorter. Okay. Because these very small and tiny changes, which are not visible by digital dermoscopy, will be visible with the super high magnification.
Very good question. Let us initiate the poll. I have a question, which is basically, and I asked Raimonds about it, to what extent this tool can become really a practical tool for daily use, okay? And I designed the question here, and I ask you please to participate in this poll to say, okay, do you see the usefulness? If yes, would you indeed be among the first users? Because so far we have not officially launched this tool. We are looking still for experts, especially really passionate dermoscopists. And I think here you have the chance to share with us your opinion in order for me to evaluate it afterwards, and by next week already approach you to welcome you hopefully into the family of optical super high magnification users. I see that.
I think we have some results.
Yeah. I mean,
I can't read it. Do you?
Oh, okay. Okay, I see that a large majority still does not have this camera, because obviously you need the camera in order to be able to test the higher magnification. It's the Medicam that is the gate to high magnification. This is excellent. Thank you very much that you participated in this poll. I see that.
More, if we are looking for the publications, I think that we can find a lot of publications regarding the application of the method. It's pigmented basal cell carcinoma. It's a flat lesions, and Elisa mentioned quite a lot, and especially in 2024, if we will use PubMed or any other way how to find these publications, they're really big information, and new data is coming from different parts of the world, also from the International Dermoscopy Society working group on super high magnification.
Excellent people. You have the chance, those of you who come to EADV, you have the chance to participate in our live events. We have again the pleasure to have some excellent experts, again Raimonds with us, on the days Thursday and Friday. So next Thursday and next Friday at the booth of FotoFinder at 1:45, I think we will start. So it's during the break. And the idea, I just want to show you what you will expect.
And with the QR code, you can get the reminder that you don't forget the event.
Exactly.
So
we'll
you can
get the
register
information.
to get the information.
And then look at this. I mean, this was from Berlin. This is what happened in Berlin. Raimonds explaining the cases, and the audience having a look. And I just want to share with you also how the session will take place. We have a patient that will be photographed.
A live patient, not the artificial one.
Yes. Basically, a live patient. Let me just share one more time my screen with you so that you see what we have here. So we have got a patient that we do the live body mapping so that the procedure is more familiar to you, and then obviously with the help of Raimonds and the patient in front of us, we are able to go into the actual workflow of digital follow-up. And this time, I will also bring the high magnification lens with me. So Raimonds, we will probably use our favorite patient, Heiko, who is gonna travel with us, and we're gonna do some body mapping, dermoscopy,
and also super high magnification.
We talk about the wonderful derm lights, and we will also select maybe a lesion for higher magnification. Yeah. So please register for these wonderful sessions on Thursday and Friday.
Exactly. And FotoFinder and DermLight will be next to each other as we're family now.
Absolutely.
We're just married, so you can.
And also don't forget to visit a session of International Dermoscopy Society, where will be a lot of interesting cases and also results of studies.
But
Excellent.
Before going to Amsterdam, you have to tell us what's this nice background picture, Raimonds.
Oh yes, you know, this is Riga. This is Riga. This is old Riga. There are a lot of yellow leaves, but at this moment there are not so many yellow leaves. It's a little bit running in front of this photo. In Riga is still summer, 25 degrees today, but looks that summer is going to the end, because the weather forecast for the next days already saying that not only by calendar and also by relations of the day and night, but not only this equinox, but also by temperature, the autumn is coming to Latvia, to Riga.
Best time to go. It's beautiful.
Wonderful.
You're welcome.
Now, dear audience, dear Raimonds, Elisa is already in her next session, but thank you so much for spending another Friday afternoon with us on this very, very exciting and new topic. And I'm sure throughout the next month and years, the more we have development, the more we will be also motivated to share it with you in the next Academy sessions.
The next Academy session will be on 11th of October.
Okay, and what's going to be the topic?
It will be Aesthetics and Dermoscopy with Ahmed Sadek and Pablo Naranjo.
Excellent. So we're going to talk about how you can use dermoscopy, again, the two-step method, for a very good diagnosis, for example, differential diagnosis of dermal melasma and these topics. I know that more and more countries are discovering the usefulness of dermoscopy in all the non-cancer areas. And I think that's why we agreed with Catherine to dedicate some time to it. So people, enjoy the afternoon.
Raimonds, you have the last words.
My last word will be
big heart to the dermoscopy community.
These kisses, sorry, Mo, these kisses are for Catherine.
Big hearts to Riga.
Yes, and big hearts to all participants all over the world.
Thank you very much.
See you next week in Amsterdam, all of you.
In Amsterdam. Richtig.
Yeah. Bye-bye.
Bye-bye. Have a nice weekend. Bye.